So we'll start with the questions. Hello, am I audible?
Oh, okay. Questions.
Yeah. So read the question.
36 years.
36-year female. She is fourth gravida, previous
Okay.
to inoperable delivery. She's come for the booking visit. Her BMI is 31 and she has
Okay.
no other comorbidity. What is her VTE score and what thromboprophylaxis plan will you give for her?
Okay. She's gravida 4
Hmm.
and BMI is 31, overweight.
Hmm.
She has no history of, and she doesn't have any previous history.
Hmm.
Actually, no, I don't know. Like, I don't have any idea.
Okay. So I'll just open the table and then from this you
Okay.
calculate the risk score for her. What is the risk score? I'll just read it. Okay. So
Okay. No.
maximum score is when the patient had previous VTE or the patient had OHSS in the first trimester. Okay. Then the score is 4. Okay.
Okay.
Then score is 3 if the patient has
OHS is ovarian hyperstimulation.
syndrome. Yes, and if
Okay.
the patient has OHSS, then you
Okay.
give thromboprophylaxis. The risk is exists only in the first trimester. So you give thromboprophylaxis only in the first trimester.
Okay.
Okay. Okay.
Okay.
So this is something which you have to remember.
Like,
Important
how
point.
does it affect?
OHSS creates this hypercoagulable state.
Okay.
It causes all this. It is associated with this pulmonary embolism because it causes the shift of the fluid from intra to extravascular. Intravascular volume contracts and there is activation of the clotting factors.
Okay.
So it for first
Okay, only
trimester
that carries, okay, score 4. And another one, previous history.
she has a personal history of VT,
Okay.
then it is score 4.
Except a
Score
single event related to surgery. Okay.
okay. And if it is previous VTE which is not provoked, unprovoked. This is previous unprovoked VTE.
Except a
Not
single. Oh, that means, if it was not complicated.
no. If
Mm.
one is because of surgery, if the patient is because of the surgery, patient is non-ambulatory for a while. That is one thing. The other
Oh,
one is
so
non-provoked. She doesn't have any surgery
like
also or any
post-LSA.
other risk factor, but she has got VTE.
So
So then
previous VTE unrelated to surgery.
surgery is 4.
Okay.
Related to surgery is 3.
Okay. Okay.
High risk thrombophilia is again 3. High risk include this all this APLA, then this antithrombin 3, all
Okay.
C protein S. Okay. Then
Okay.
medical comorbidities, even SLE is
Okay.
3. Cancer, heart failure, inflammatory polyarthropathy, inflammatory bowel disease, nephrotic syndrome, type 1 diabetes, sickle cell disease. All this is category 3. Okay.
Okay.
Then then comes category 1 and 2. So 2 is BMI more than equal to 40 is category 2.
Okay. BMI more than 30 is one, more than 40 is two.
Yes. And then this is also category 2 cesarean section in labor. So this 432 you remember. Rest
Okay.
everything, all the risk
Three
factors come
is
under one.
high risk thrombophilia related to surgery. 4 is previous venothromboembolism, not related to surgery. Okay, 3 is related to surgery, high risk thrombophilia, and SLE, all these conditions. So, one, rest all one.
Okay.
3, another 3, hyperemesis is also 3.
Hyperemesis is also
And
3 and any surgical procedure in pregnancy and puerperium except this episiotomy repair is 3.
okay.
So any procedure during pregnancy is also 3. This is also important. So if
What
the
is
patient is
except?
undergoing any surgery in the pregnancy like appendectomy or cystectomy
Okay,
or
okay, okay,
postpartum or in the
okay.
postpartum, you have to give them in the postpartum period some kind of
Okay,
thromboprophylaxis.
they'll be mobile lock.
Okay. Even DME.
Appendectomy come or any surgery or except episiotomy. Okay.
Yeah. Any
Okay.
surgery.
Yeah,
So
any surgery like related to okay
pregnancy and
procedure.
puerperio.
Okay.
Okay.
Okay, ma'am. Okay. And another one, cesarean section in labor, that is two.
Yes.
And here obesity, okay, that one. And cesarean section in labor is two. What is that shifting from labor ward?
Shifting from labor ward means?
No, I mean what it is. Cesarean section in labor means normal LCS.
No, no. If the patient is in second stage of labor or active being induced, you are doing cesarean because of any reason, MSL, fetal
So like
bradycardia,
emergency
rupture.
cesarean. No?
Yes,
Okay. Why elective cesarean is one only and emergency cesarean is two?
because then morbidity is more. No, cervix is
Okay.
dilated. Sometimes
Okay.
it's second
Oh, there
stage
may be some
pregnancy.
reason.
Yeah.
Okay.
Okay. And the
Okay.
other reasons which are category one, I'll just read. If there is family history of unprovoked or estrogen, family history of VTE is one. Known
Mm.
low thrombophilia is one. Age more
Okay.
than 35 is one. Obesity BMI more than equal to 30 is one.
Okay.
Activity more than equal to 3, smoker, gross varicose vein, preeclampsia, ART, IVF, multiple pregnancy, elective cesarean, mid cavity, prolonged labor, PPH more than 1 liter. This PPH 1 liter you have to remember, and prolonged labor more than 24. This timing you have to remember because they might give you timing that the labor
Prolonged
was
labor more than 24 hours and PPH more than 1 liter. Okay. So
preterm
more
birth.
than 1 liter. Okay. Not less than 1 liter. It will not come under the. It will not even get score 1. It will be 0 then. If it
Yes.
is less. Okay.
Then stillbirth in current pregnancy is 1.
Mm.
Current systemic infection is 1. Immobility, dehydration is 1. So any risk factor you can think in pregnancy is 1. Okay, other 4, 3, 2 you remember. Other
Okay.
things you have 1. So now in all these three questions you have to tell me what is the VTE score, and then we'll discuss how you give
Okay.
thromboprofile.
Okay, ma'am. So here her BMI is 31,
Hmm.
score 1,
Okay.
and Gravida 4. That's all, score 1. That's it.
No, parity also I told, age also I told.
Oh, oh, okay, okay. Age is more than 35 and parity, okay, more than 3. Gross
So what
variation.
is the score?
Okay. So 1, 2, 3.
Yeah, 3. Okay.
One is
The
for her
next,
BMI, the other one her age, another one parity.
yes. And second question, just tell me the score and then I'll tell you how to do give
Yeah.
thumb.
Okay.
Next question, what is the score?
Yeah. 4, ma'am.
Yeah, because it is IVF OHSS.
Okay.
So
Developed
you already
OHSS
told
also.
you'll give thromboprophylaxis for how long?
For her,
If it is the only risk factor, it is
1 week.
for how long? It is only in the first trimester. So you'll give her thromboprophylaxis only in the first trimester.
Okay. Mm.
Okay. The
Okay.
next question.
1.
Yes, it is score 1. So how do you decide how to give the thromboprophylaxis? If the total score antenatally is more than equal to 4, then you have to give thromboprophylaxis starting from the first trimester. If score is 3 or more, then from 28 weeks. Score
Okay.
more than equal to 2 postnatally, then you give at least for 10 days, and
Okay.
if admitted to the hospital you give thromboprophylaxis. Agar if there is prolonged admission more than equal to 3 days, then you have to give thromboprophylaxis to the patients. So postnatally more than equal to 2, antenatally more than equal to 4, you give it from the beginning. More than
Okay.
equal to 3, you start from 28 weeks.
Okay. And
Okay.
it will be continued until labor, before labor.
patient has received this thromboprophylaxis during pregnancy, you have to give them for at least 10 days postpartum, depending on what the score is. If it is more than 2,
Mm.
uh, then you have, if she has received during pregnancy, you have to give it for 6 weeks. That means
Okay,
definitely her score is more. Okay, I'll be discussing that also in
okay,
a while.
okay.
Okay,
No.
so in the first case, when the score is 3, for how long will you give thromboprophylaxis?
If the score is 3, we are starting from 28 weeks
Yes,
for 6 weeks.
yes, because you're giving it antenatally. Second,
This is number score 4. We have to start from first trimester.
you will give only in the first trimester,
Yeah, only in the first trimester.
and you will reassess in the postpartum depending on the score. You will decide whether to give. As of now, just in the first trimester.
Okay.
Okay. Next question.
And this last one.
And this is actually score 5 because IVF treatment is also there. No, 1+1.
But because due to IVF only, she developed OHSS.
Yeah, yeah, but IVF is also given a score of 1.
Oh,
No.
okay, okay, okay. So totally 5.
Yeah. Next question.
Okay. And the last one score is 1 here.
Hmm. So
So she'll does she need only
no,
for 10 days?
no. Score 1 more than 2 only you give. No.
Yeah, for one no need.
For 1, no need, but you will give them mechanical stockings, ask them to ambulate. You will not write no need, but you'll do other, give other mechanical things. You'll not give this anticoagulants.
Prophylactic.
Give them
Okay,
stockings. You'll give them stockings. You'll ask for early ambulation. Keep them hydrated.
okay.
Okay, so that will be the best answer. So this is for the antenatal. You just remember that in the table that I have told. If
Hmm.
one you have to remember, that is something which you have to remember. From this
Okay,
table, you can see that this I've already told. Score 4 is high risk when it is unrelated to surgery.
okay,
All these are intermediate risks. You have to remember the score number. Okay.
okay,
So based on that, you decide if it is high risk, like if the score is more than 4, you have to start from early pregnancy,
okay.
continue it for 6 weeks postpartum. So here you can see in the postpartum,
Hmm.
what is high risk, where you have to give it for at least 6 weeks. If there was previous VTE, if there is
Okay,
previous VTE, anyways it is scored more than either 3 or 4, depending on whether it is related or unrelated to surgery.
okay.
Anyone receiving antenatal LMWH, you have to
Hmm.
give them for at least 6 weeks.
Okay,
Okay. High risk thrombophilia, you have to give it for 6 weeks. Low risk thrombophilia plus family history. So this is again you have to give it for 6 weeks.
okay. What if there is no family
You have
history
to
in
remember,
low risk thrombophilia?
if they have a family history of thromboembolism and
Okay,
self they have low risk thrombophilia, then you have to give it for 6 weeks. So this much you have to remember. High risk pala, in which all conditions you have to give it for 6 weeks. Okay,
okay,
otherwise score more than 2, you have to give for 10 days. Okay,
okay.
okay, and if
So
the
when we start from first trimester, only in first trimester. Whenever we start,
that
are we
that is
not continuing in the
one,
second trimester?
that is only for 2 conditions, OHSS and hyperemesis, because hyperemesis will only be there in the first trimester.
Oh, okay, okay, okay.
In there. So that is the only 2 condition where you give it only in the first trimester. Other
Okay.
conditions you continue from start from first trimester, give it throughout the pregnancy, also continue it for 6 weeks postpartum.
Okay, okay, ma'am.
Okay, understood. So
Yeah,
try solving questions on this. This is very important.
okay.
Okay. But the gist of it, you have to remember this table, you have to remember this table, and then
Hmm.
you also have to remember what are the high risks when you have to give 6 weeks,
Okay,
and when you have to start from first trimester and this thing. And if the factors are less, like
hmm.
if the score is less than the one which I have told antenatally, if it is less than 3, then it is you will ask them to mobilize early and avoid dehydration. Okay.
Okay, okay.
So that will be the plan. Okay, so next question.
What regional? Only what we shouldn't give.
Regional, spinal or epidural.
Hmm. Epidural.
When can it be given? After LMWH therapeutic dose?
After 24 to 48 hours.
Yes, after prophylactic, the patient is on prophylactic dose, you
Hmm.
can give after 12 hours,
Okay.
therapeutic dose after 24 hours. And once
Okay.
the patient comes in labor, then you will not give any further dose.
Okay.
Okay.
Okay. She's already in labor. Hmm.
So this is about the how you can interrupt. It depends if like women who are receiving antenatal LMWH should be advised that if they have any vaginal delivery, he or once the labor begins, they should not inject any further LMWH. Okay,
Okay.
and regional techniques should be avoided if possible
Hmm.
until 12 hours if the patient is on prophylactic LMWH,
Okay.
and for therapeutic it is 24 hours.
Okay.
Okay, because there is
Okay.
risk of formation of epidural hematoma. Okay,
Okay.
and
Okay.
NFWH should not be given for 4 hours after you have given spinal. At least
Okay.
for 4 hours, you should not give further LMWH. Okay, or after
Okay.
the epidural has been 4 hours after the epidural has been removed, and the catheter should not be removed within 12 hours of the most recent LMWH.
Okay.
Okay, so you'll plan accordingly about the
Because
removal
of the bleeding.
because of the spinal hematoma formation.
Okay.
Okay, because it's an anticoagulant.
Okay.
Okay, the first thromboprophylactic dose of LMWH, like after a normal delivery, it can be given as soon as possible, provided bleeding everything has been settled and there is no PPH. And
Okay.
regional anesthesia not used. If regional anesthesia used, then after 4 hours. Okay, if it is prophylactic. Okay.
Okay.
And women at high risk of hemorrhage with risk factors including major APH, coagulopathy, progressive wound hematoma, suspected intra-abdominal bleeding, and postpartum hemorrhage may be managed by anti-embolic stockings, foot impulse devices, or intermittent pneumatic compression devices. In those cases, unfractionated heparin may also be considered because it is short acting.
Okay. Mm.
Okay. If a woman develops a hemorrhagic problem while on LMW, the treatment should be stopped and expert hematologist advice should be sought.
Okay.
Thromboprophylaxis should be started or reinstituted as soon as immediate risk of hemorrhage is reduced.
Okay. What is that pneumatic compression device?
There are two types of devices. One is anti-embolic stockings, which we give, which
Okay.
create a pressure on the ankle, and like basically here we are worried about the DVT and pulmonary embolism. We don't want
Okay.
the stasis of the blood in the this thing. So
Mm.
with the stockings, they maintain the blood flow by maintaining a pressure on the calf veins, and there are something called pneumatic devices also. These are also like they also create give a kind of pressure around the ankle.
Okay.
There are also foot impulse devices. Various devices are available.
Okay.
Okay, the conditions where you will not give or cautiously use LMWH if there is known bleeding disorders like hemophilia, von Willebrand disease, acquired coagulopathy, a patient having active antenatal or postpartum bleeding, when considered at risk of major hemorrhage if there is thrombocytopenia, in case there has been a stroke within 4 weeks, or a patient has severe renal disease or severe liver disease or uncontrolled hypertension. So
Okay.
these are the contraindications. Then how do you decide? It is based on the weight. Less than 50, it is 40 BD. This is the therapeutic dose. Okay.
Okay. Mm.
Or 60 day.
Okay.
60 to 69, it is 60. So 40, 60, 80. This way you can remember. And it is 50 to 70, 70 to 90, 90 to 110. Like that you can remember.
Okay.
Okay. And it is 40, 60, and
80,
this.
100, 120. Okay. Even numbers. Mm.
Okay. So
Okay.
this you can remember. Okay.
So 80 BD means 120 OD. It is not 100.
Yes.
Okay.
Then what most commonly you use low molecular weight heparin, right?
Yeah.
About we have studied. Other agents that can be used, one is unfractionated heparin.
Okay.
So, however, it is given when a patient is at very high risk of thrombosis. Why? Because if the patient is very high risk of thrombosis, you cannot wait for those 12 and 24 hours. Otherwise,
Okay.
patient might develop clot. This unfractionated heparin, it is short acting. So basically, interval between the prophylactic dose of unfractionated heparin and regional anesthesia is 4 hours. While for LMWH, I told you it is 12 hours.
So it
Okay.
is short acting but fast in action.
Yes.
Immediate action. Okay.
Okay. So, in patients which are at very high risk, where you cannot wait for so long, you give unfractionated heparin. But why are we not giving it to everybody? Because there are two problems with it. One is HIT syndrome, which is heparin-induced thrombocytopenia. Second is osteoporosis. Okay.
Okay. Mm.
So it causes thrombocytopenia. So you have, once you're giving unfractionated heparin, you have to monitor the platelets every
Mm.
2 to 3 days from 4 to 14 days, or of from days 4 to 14, or until the heparin is stopped, because there is risk of heparin induced thrombocytopenia.
Okay.
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 Then other agents that can be used are donaperinoid or fondaparinux. They are reserved if the patient is intolerant to heparin, then you can use it. Okay.
Okay. Okay. This antagonist is used when given in higher doses.
Antagonist, which antagonist?
Protamine sulfate.
Yes, so in case there is toxic, like suppose a patient has already taken unfractionated heparin and you need to do an emergency cesarean
Case
section.
overdose.
To have a reversal agent, you can give protamine and do a cesarean if you don't have time to wait for 4 hours.
Okay.
For LMWH, we do not have any antagonist.
Okay.
Okay, so this is
And
another
for this dosage, ma'am, they will not ask, right?
dosage. They'll not ask.
For
Yeah,
LWH. Okay.
dosage generally they'll not ask. Okay.
Okay.
Then donaperinoid and fondaparinux, they are reserved for women who are not tolerating heparin or low molecular weight heparin. Aspirin is not recommended as a thromboprophylactic measure. Warfarin, the problem with warfarin, I told you in the last class also, it causes embryopathy, nasal
Okay.
hyperplasia, stippled long bones, all that.
Mm.
So it is not recommended. Like it also can be used in patients who are at very high risk of thrombosis.
Okay.
One big problem with it is long acting. It has to be stopped at least 5 days before any surgery. Okay.
Okay.
So I told you in the patients with mechanical valves also, 2 weeks prior to the planning delivery, you have to change it to low molecular weight heparin.
Okay.
Okay. So that
Okay.
so only in patients with mechanical heart valves you can use it, who are at very high risk of thrombosis, and you cannot compromise there. Then
So
dextran.
actually, we anyhow we have to stop it 2 weeks
Yes.
before, right? Prior to
Yes.
surgery for people who have this mechanical heart valves.
No. For it depends on the gynae or obstetric surgery. If the patient is planned for delivery, then 2 weeks prior to that you have to switch to low molecular weight. For
Okay,
gynae
what is the
surgery,
regimen?
5 days.
People with mechanical heart valves, they are suitable for warfarin.
Mechanical heart valves, basically I told you, patients who have mechanical heart valves, they are lifelong dependent on anticoagulants, right?
Yeah. Mm.
Because they are at risk of valve thrombosis and valve degradation.
Okay.
Okay. So they
Okay.
require coagulation, lifelong anticoagulation, so that valve thrombosis doesn't occur and the functionality is retained.
Okay.
In those cases, warfarin, because it is orally taken,
Acting
heparin
also.
has to be injected. Okay.
Okay.
One advantage is that. Second, it
Okay.
is longer acting. Okay.
And okay, when they stop
More
prior
efficacious.
to surgery, okay, will the thromboprophylaxis will be replaced or stopped?
When
Prior to surgery, they are stopping warfarin. Will
so
they replace it or they'll just stop?
they, like in like 2 weeks prior to
Yeah.
delivery, they change it to heparin.
Okay.
and it takes some time. There is this
Okay.
process is called bridging. So
Okay.
they continue warfarin, they
Okay.
start reducing the dose, they
Okay.
start this NMWH simultaneously, and they
Okay.
monitor the factor 10A levels. When the factor 10A levels they reach the therapeutic range 0.8 to 1.2, they slowly stop this warfarin. So
Okay. Okay.
that bridging takes some time. So that's why 2 weeks prior to the
Yeah.
delivery. Okay. Then dextran, ideally it should be avoided antenatally and intrapartum because of the risk of anaphylactoid reaction. Then there are new agents which are called as non-vitamin K antagonist or anticoagulants, and which ideally should be avoided in pregnant patients and who are breastfeeding. Okay.
Okay.
So this was about the pregnancy. Then about VTE and PE. So DVT and PE. So like if the patient comes to you who is pregnant or in the postpartum with sudden respiratory distress, and you are suspecting pulmonary embolism. Okay, you what you have to do? You have to do chest X-ray, ECG, full blood count, urea electrolytes, LFT, and in case you are suspecting pulmonary embolism, you start low molecular weight heparin. Okay,
Okay.
even before the results are confirmed. Then you look for signs and symptoms of DVT. What will be the signs and symptoms? There will be calf tenderness, calf
Mm.
swelling. Okay.
Mm.
In case there are signs and symptoms of DVT, then you do a duplex compression ultrasound.
Okay.
Okay. And if it comes out to be positive, then you start therapy. You continue. You've already started. You continue.
Okay.
Okay. In case there are no signs of and symptoms of DVT, then you see the chest X-ray. In case chest X-ray is normal, then you do a VQ scan. If chest X-ray is abnormal, you do CTPA scan to
Okay.
confirm pulmonary embolism.
Okay.
Then, if once the pulmonary embolism is confirmed, you continue. In case it has been ruled out, then
Mm.
you see whether the clinical suspicion is low or high. If there is low, then you discontinue LMWH. If it is high,
Mm.
you you do another test to see, or you repeat the test to see whether it is
Okay.
there or not while continuing LMWH.
Okay.
Okay, because pulmonary embolism is a life-threatening condition.
Okay.
There is a clot in the vessels in the heart, then it will severely compromise the blood flow and cause sudden death. So you don't
Okay.
want that. So that's why even before confirming, you start anticoagulants. And this
Okay.
asks, so how will you proceed? You'll start if you're suspecting pulmonary embolism, you'll start anticoagulants, and then you will see whether first you will see whether there are signs and symptoms of DVT. If there are signs and symptoms of DVT, then you do to confirm it, you will do a Doppler scan, Doppler of
Okay.
the legs to see whether there is actually a DVT. In case
Okay.
there are no signs and symptoms, there is only pulmonary embolism, that is the clot is coming from somewhere else. So then
Mm.
you see the chest X-ray. If chest X-ray you are seeing the findings of P will be bronchovascular markings will be prominent.
Mm.
There can be consolidation, symptoms of congestion and all that. In case X-ray changes are there, then you do VQ scan. If it is not there, then you do CTPA scan. So this also you have to. Okay.
Okay.
Then about the investigations, ECG, it is
What
up.
will find in CTPA scan?
CTPA is like a CT scan only, but it is a CT along with the angiography. So,
Okay.
okay,
Okay.
it is computed tomography pulmonary
Okay.
angiogram.
Okay.
Okay. Then ECG, it is abnormal only in 41% cases. ECG changes include most common of these is T wave inversion, S1 Q3 T3 pattern, and right bundle branch block. But it is abnormal only in 41% cases.
Okay.
X-ray, you might find like symptoms of pneumonia, pneumothorax, or lobar collapse. D-dimer testing ideally is not recommended during pregnancy because anyways in pregnancy D-dimer is raised.
Okay.
Then duplex ultrasound when you are suspecting this DVT, then you do it.
Okay.
And in women with suspected pulmonary embolism with signs and symptoms of DVT, VQ scan or CTPA should be done. If chest X-ray is abnormal, then you do CTPA. If it is normal, then you do VQ.
Okay.
Okay. And VQ scan during pregnancy, it has a slightly increased risk of childhood cancer, but it is associated with lower risk of maternal breast cancer. In both situations, the absolute risk is very small. Okay, so it is like there is a small risk of with VQ scanning, there is a small risk of childhood cancer. Okay.
When there is a suspicion and no, when are we going for CTPA and when do we do VQ scan?
CTPA is done if there is chest X-ray is normal.
Okay,
If it is abnormal, you do VQ.
okay,
You are only doing it when you have very strong suspicion. VQ scan.
okay,
Why? Because VQ scan has a risk of childhood cancer developing.
okay.
Okay. Then before starting the anticoagulants, what baseline test you should do? You should do a full blood count, coagulation screen, urea electrolytes, liver function test, thrombophilia screen. All this is recommended.
Okay.
Okay. Initial anticoagulant treatment of VTE in pregnancy. In clinically suspected DVT or PE, you have to treat these patients with LMWH. It should be commenced immediately until the diagnosis is excluded by objective testing. Okay, this
Okay.
I've already told, unless the treatment is contraindicated. And LMWH is preferred over unfractionated heparin because it is more effective. There is less risk of hemorrhagic complication, lower morbidity, and less risk of heparin-induced thrombocytopenia and
Okay. This
osteoporosis.
is morbidity or mortality? Mortality.
Actually,
And what is the prophylactic dosage?
prophylactic doses is 1 mg per kg OD
Okay.
dose, and 1
Okay.
mg per kg BD is therapeutic.
Oh, okay.
Okay. So that's what here also you can remember it very easily. I showed you that table, no? So see, if it is 50, approximately like less than 50, you give 40 mg BD.
Okay.
So this is
Okay.
therapeutic.
Okay. If they
This
specifically
is
give the patient's age, we have to mention the right dose.
huh?
No, even if it is prophylactic dose, if they mention the weight of the patient,
Yeah,
we
it
have
is
to give the
dictated by
correct
the
answer.
weight.
Yeah, if suppose they mention as 80 kg.
So it
Okay.
is easy to remember. See, 50 to
Yeah.
70 average is 60. So this is
Okay.
therapeutic, 60 BD.
Yeah, this I will memorize.
It is easy only. 70 to
Okay.
90 average is 80, right?
Okay.
So
Mm.
80 mg BD.
Okay.
Okay.
Okay. Continuous even numbers.
Yes. And then where were we? Yeah, this we have started. Then we come over to the next. This is a very recent talk. You might get question on it.
Previous slide, ma'am. After basic investigation.
We have done.
This you finished. Yeah.
Okay.
Okay.
So we have studied about obstetrics now. Now we come over to gynecology.
Okay.
Okay.
Mm.
So in gynecology, without thromboprophylaxis, if you do not get thromboprophylaxis after surgery, the incidence of confirmed DVT it is as high as 40%. It is ranges between 17 to 40%, and the
Okay.
risk is highest in the first 12 weeks, exists in the first 12 weeks, and highest in the first 6 weeks. Okay.
Okay.
Then there is something called as HAT. HAT is hospital acquired or hospital associated thrombosis, which is defined as any venous thromboembolic event which is occurring within 90 days of hospital admission. And this accounts for 50 to 60% of all thromboembolic events.
Mm.
Okay.
What is
BTE,
the point? Without thromboprophylaxis, incidence of confirmed DVT in major abdominal surgery ranges from 17 to 40%. That means there is a risk for 17 to 40%.
if you do not give thromboprophylaxis, so it is very important to give it.
Okay.
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 Then BTE in early pregnancy and OHSS. So OHSS, I already told you the score is 4.
Yeah.
Okay, so risk for BTE increases from first trimester. This is attributed to the hypercoagulable state in the pregnancy. Thrombin generation increases in women as early as 5 weeks. and it has been seen that there is 100-fold increased of VT in pregnancies associated with IVF that are complicated by OHSS, as opposed to 5-fold increase in the IVF pregnancy without OHSS.
Okay.
So, in pregnant females, pharmacological thromboprophylaxis and severe OHSS should be continued for the duration of first trimester. Okay. If the
Okay.
patient has undergone
Suppose,
IVF and has OHSS, then you have to give it for the first trimester. And suppose what happens, the patient doesn't conceive.
mm,
Okay, so then you can discontinue it at the time of withdrawal date.
oh, okay. So prior to conception.
Okay.
Who do not conceive, it can be discontinued at the time of withdrawal bleed. Okay. Suppose if she is pregnant, it is continued.
For the first.
If she is conceiving, okay, it is continued until her first trimester.
Yes.
So until 12 weeks. Okay.
Okay.
If suppose if they are starting by 8 week, okay, by 8 week means it will go on. If suppose if they are starting, got to know only by 11th week, is it enough
No,
for?
it's usually present early in the pregnancy only. It
Okay.
will be presenting immediately after IVF only mostly.
Okay.
Then pathophysiology of thrombosis, this we already know, Virchow's triad. If there is endothelial injury because of any surgery, inflammation, stasis because of immobility, venous obstruction, hypercoagulability because of cancer, abdominal or pelvic surgery, underlying conditions like inflammatory bowel disease, nephrotic syndrome, sepsis, pregnancy and puerperium, thrombophilia, estrogen therapy, all these are the from the pathophysiology. Risk factors, this so we have for thrombosis, if the age is more than 60, BMI is more than 30, medical comorbidities, previous VTE, cancer, pregnancy, postpartum, patient on CHC, smoking, black race, it is more. Acute admission with inflammatory or intra-abdominal condition. There could be procedural related risk, like if there is significant reduced mobility for more than equal to 3 days. Laparotomy has higher risk as compared to laparoscopy. Surgery is prolonged, and if there is procedural complexity.
Okay.
Okay. Then, in case a patient has malignancy, so malignancy further increases the risk of this thing, VTE. So, in any patient who is undergoing surgery for malignancy, this you again have to remember, you have to give extended thromboprophylaxis and you have to give dual. Dual means you have to give mechanical as well as low molecular weight. Mechanical, you give anti-embolic stockings or pneumatic compression devices and LMWH for 4 weeks,
Okay.
irrespective of the score. Okay.
Okay.
Then, if the patient is on
So
CHC
here
again,
it is prophylaxis, so OD dose only.
yes.
Okay.
Okay. So, risks with combined CHC. So, if the patient is on CHC, CHC again increases the risk I told you, right? So,
Yeah.
if you're planning for surgery and a patient is on CHC, you have to stop it at least 4 weeks prior to the surgery.
Okay.
Okay, and restart it only after 2 weeks post surgery. This you have to remember, 4 and 2.
Okay.
Stop it 4 weeks prior and restart it 2 weeks after.
Okay.
About HRT, HRT is comparatively safe and you need not stop it prior to the surgery. Okay.
Okay.
So this is something which you have to remember. CHC you have to stop, HRT no need to stop.
Okay.
So transdermal HRT of these is safest. Estradiol is associated with the lowest risk, then conjugated equine estrogen. When considering combination, the lowest risk is with estradiol dihydrogesterone and maximum is with conjugated equine estrogen and medroxyprogesterone acetate. The risk is less with estrogen only than with combined estrogen and progesterone. Overall risk of VT is not increased by continuing HRT in the perioperative period. So you can continue HRT.
Okay.
Important point. HRT does not need to be stopped prior to surgery. It should be considered as a factor while assessing risk. So you give it another score of 1 while you are assessing the risk. Okay, but you need not stop it. Then about surgery, laparoscopy has less risk as compared to laparotomy, and abdominal surgery has more risk as compared to vaginal surgery. Okay.
Okay.
And the highest risk when the surgery is performed, like hip and knee replacement and cancer surgery, they
Because
carry the highest
thrombin.
risk. Yes. For cancer, patient undergoing cancer surgery, what thromboprophylaxis will you give? Huh?
Manual as well as low molecular weight heparin.
Dual. For how long?
Dual for
For, for how long?
3 months,
No, for 4 weeks.
4 weeks. Okay.
3 months you only give if the patient has VT. That is therapeutic.
Okay, yeah,
Prophylaxis you
this is
never.
prophylactic.
Then what are the modes of thromboprophylaxis? So modes include ambulation, mechanical thromboprophylaxis and pharmacological agents. Mechanical include anti-embolic stockings, graduated compression stockings. So these work by exerting compression around the ankle. About 8 millimeter mercury pressure is exerted, and it has been seen that the patient adherence with knee length stocking, because they're more comfortable, is than hip is more than with thigh high stockings.
Okay.
So knee length are generally preferred by the patient. Intermittent pneumatic compression devices, they can also be used. They prevent peripheral pooling of the blood in the legs. So Warshaw's triad, stasis I told you is one of the component. So they prevent the stasis of the blood. And
Okay.
it has been seen that these reduce the incidence of DVT by 60%. So they are
Okay.
quite effective. Anti-embolic stockings, in which all conditions you should not give them in case there is peripheral arterial disease, peripheral arterial bypass grafting, peripheral neuropathy, or skin conditions like dermatitis. In these conditions, you will not be able to give them.
Even in diabetic neuropathy.
Yeah, if they have peripheral neuropathy, yes.
And how
So,
about
we
varicose
know
vein stocking, ma'am? It should be given up until thigh only, or up to knee is enough.
anything can be given, but patients generally tolerate knee one better
Yeah.
up,
Mm.
because they're quite tired, so they
Yeah.
are uncomfortable for the patients. Okay. Then about the drugs, about comparison between fondaparinux versus LMWH. According to the NICE, it can be used as an alternative to LMWH. It is also excreted by kidneys, but the disadvantage of using fondaparinux is it has a longer duration of action, and we do not have a reversal agent for it. So
Okay.
breathing complications, they are because of the longer action, they are more with fondaparinux. Okay.
Okay.
Then about direct oral anticoagulants. So what are these direct oral anticoagulants? We have apixaban, dabigatran, rivaroxaban, edoxaban. Okay.
Mm. Okay.
These have a rapid onset of action. These are short acting, and there is low bleeding risk compared to warfarin. They have good safety profile, and unlike warfarin, they do not require regular blood monitoring.
Okay.
And the reversal of anticoagulant effects, in we have reversal agents also. For dabigatran we have idarucizumab, and for an edinex antixanet alpha for apixaban and rivaroxaban. We have reversal agents for them as well. Okay.
Okay. Then why are we not giving? Because of the cost.
We can give it. We are not giving. They are not given during pregnancy. They are not safe.
Okay.
Otherwise outside pregnancy they are being given.
Oh, in gynec. Okay.
Yeah. So caution, this is the same as I've told you in the previous guidelines. For contraindications where you have to be cautious. Patient related, like if there is active bleeding, bleeding disorders, patient on concurrent use of other anticoagulants, acute stroke, low platelets, high BP.
Okay.
If the patients are at high risk of bleeding, or if you have put regional anesthesia. This already
Okay.
we have discussed. So early pregnancy, this is just briefly what we have already discussed. So in cases of pregnancy, if there is personal history of VT with score more than equal to 4, OHSS or hyperemesis, so all these are high risk. So you
Mm.
have to give pharmacological thromboprophylaxis after ruling out contraindication. You give actually both dual. You give pneumatic compression devices also. or compression stock, graduated compression stockings along with LMWH. For ectopic pregnancy and miscarriage, I told you anything, any surgery during pregnancy or puerperium, it is high risk only. So you calculate the score. If the score is more than equal to 4, again you have to give them. Okay.
When ma?
If
The next.
any surgery during pregnancy and puerperium, including surgery for ectopic and miscarriage. So
Okay.
it is considered as high risk only. Okay, I'll be showing you the score. So you can see it is score 3 for any surgery, even miscarriage has a score 3.
Yeah, 3 only, no, not 4.
Yes. Yeah, but if they have suppose additional risk factor, age, BMI,
Okay. Oh,
they
yeah. Okay. Okay. Score. Okay. Total score.
have to give dual thromboprophylaxis. So pregnancy alone has any surgery during pregnancy,
Okay.
including miscarriage, has a score of 3. This you have to remember.
Okay.
It is a high risk only.
What it is if contraindicated or the graduated stocking? IPC is?
Pneumatic compression. If you cannot give pharmacological agents, then you have to give mechanical. No,
Okay.
there's no other choice.
Case. Okay.
Okay. Then for gynecological surgery, you'll see whether there is personal history of thrombosis or malignancy. Then it is high risk. Then you have
Okay.
to give pharmacological. If in case they're contraindicated, then at least stockings or pneumatic compression devices. If no, then you assess the risk according to the score. And if
Mm.
it is high or highest risk, you have to give. Otherwise, low risk, you do not give. CHC, I told you, you have to stop 4 weeks prior. HRT, no need to stop.
Okay. Which is considered low risk?
I'll be telling
Those,
you. So
yeah.
this is
Okay.
to calculate the score. Based on the age, you like I'll the
Like
highest risk.
they are 1 or 2.
Yeah. So the
Score falls.
highest is if there
Okay.
is +5 score where there is any hip, pelvic, leg fracture or stroke or multiple trauma or acute spinal cord injury causing paralysis. So this is score 5. Then
Okay.
other high scores are if the age is more than equal to 75, pregnancy or puerperium if there is any surgery or even miscarriage, personal history of VTE score 3, family history of unprovoked VTE score 3, history of high risk thrombophilia is again score 3. So at least score these scores you have to remember. Again a new table. Okay. So according to this you calculate the total score. If the score is 0, it is low risk. You just
Okay.
ask them to ambulate. Okay.
Okay.
Score 1 to 4, it is moderate risk. So there
Okay.
you have to give only mechanical thing during hospitalization. Okay.
Okay.
5 to 8 is high risk where you give both mechanical as well as LMWH or LMWH alone for 7 to 10 days, and
Okay.
more than equal to 9 score is the highest risk where you have to give everything for 30 days.
Okay.
Okay, so here cancer is cancer is this 3. There is the cancer. Cancer or cancer treatment is +2, right?
Yeah.
But still, if any patient is going for surgery for cancer, you have to give it for 4 weeks. This we have already studied, right?
Mm.
Thromboprophylaxis you have to give for 4 weeks, right?
No, no. Prophylactic doses for 4 weeks.
If the patient has cancer, yes.
Yeah.
So in all these cases, you're just calculating the score and giving prophylactic only.
Okay.
Therapeutic only give if the patient actually has thrombus.
Okay.
And then this question.
Which of the following is not true about hospital
सवाल से
acquired?
डर नहीं लगता साहेब गलत जवाब
Hospital. Which of the following is not true about? Oh, this is the expansion.
Hmm.
What is hospital? Okay. Any venous trauma occurring? Option C.
No,
It
it
does.
is within 90 days.
Okay. So it accounts for 50 to 60%.
Yes.
Okay.
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 Next question.
Option C. It is continued only if they are pregnant. Otherwise discontinued.
So other options are wrong.
Which is true. C is true and 100, but it's not 100-fold. There will be like it is risk only. So in all cases, so we have to take it 100-fold risk only.
Yes, I told you, no. So with OHSS, it is
4
100-fold
itself,
increase.
4.
100-fold
Okay,
increase
they
with
have given.
IVF.
Oh, okay,
Yes.
they are giving high score also. Okay.
And second one is
Pharmacological trauma prevalence, severe fortitude. Yeah, yes, ma'am, all the above.
is all the above. Next question.
This surgery should be given for post-cancer surgery. 4 weeks is for, it is a prophylactic. Post-cancer, how long we'll give? Prophylactically for 1 month, 4 weeks.
Yes, so 4 weeks.
So post-cancer surgery,
You have to give it for 4 weeks.
4 weeks only.
The next question.
Highest risk people who undergo hip and knee surgery.
Yes, it is core plus 5. Then
Mechanical thromboprophylaxis. Patient. Okay, first is correct. Yeah, option B, option A and C are true. Option B.
B. Yes, it is B. It reduces by how many percent? How much percent?
I don't remember how much.
By 60%. It reduces by
Because
60%.
it is advised, no, along with even heparin. Okay.
Okay, then last guideline on this about the bridging thromboprophylaxis, perioperative management on oral anticoagulants and antiplatelet agents. So these are the anticoagulants and the mechanism of action. Warfarin is anti-vitamin K.
Okay.
Heparin is antithrombin. Then direct oral anticoagulants, DOACs, these inhibit factor 10A and factor 2A and have prothrombinase activity. And aspirin and clopidogrel are antiplatelets.
Okay.
Okay, so when will you refer the patients to bridging clinic? So if a patient is on oral anticoagulants like warfarin, so I told you it has to be stopped if it is an obstetric, like if you're expecting delivery, then at least 2 weeks prior. For gynecological procedures, at least 5 days. But if the patient is at very high risk of thrombosis, you have to bridge the gap. Okay. So you for this 5 days, it is not that you will not give any thromboprophylaxis. You shift them to LMWH or unfractionated heparin. So,
Okay.
which all patients do you refer to the bridging clinic? You refer if the patient is at high risk of thromboembolism. So, high risk of thromboembolism include if the patient is at high risk of thrombophilia, like with patients with APLA or antithrombin 3 deficiency, patients undergoing cardiac valve insertion, patients with history of heparin-induced thrombocytopenia or heparin allergy. So you want to give them like thrombo bridging only in the bridging clinic because they are at very high risk. Okay.
So only for obstetric cases only we are stopping 15 days prior. Otherwise, for if it's gynec procedure, only 5 days prior.
Yes.
Okay.
Okay. So bridging in females with women with on taking warfarin. So on it should be stopped 4 to 5 days before the surgery, irrespective of the risk of bleeding, whether it is low risk or high risk. It has to be
Okay.
stopped 4 to 5 days prior. So
Okay.
preoperatively, you assess whether the patient is at low thromboembolic risk, high intermediate thromboembolic risk, or high thromboembolic risk, or very high thromboembolic risk. If the
Okay.
patient is at low risk of thromboembolism, they do not require any bridging. Okay, then
Okay.
you stop and you call them for surgery. If the patient is at intermediate risk, then you have to bridge them with LMWH, and LM prophylactic LMWH should be stopped 12 hours.
Okay.
Okay. If the
Okay.
patient is at high risk, you bridge them with therapeutic dose of LMWH. Okay.
Okay.
And
Okay.
therapeutic dose has to be stopped 24 hours prior.
So here it means that for intermediate risk, we are going to give OD dose only, and
Yes.
is it like that?
Yes,
What does
yes.
it mean actually?
For intermediate risk of thromboembolism, you give OD dose. Prophylactic is OD dose. 1 mg per
Okay.
kg OD. Therapeutic is
Yeah.
1
Okay.
mg per
Here.
kg.
Okay. Treatment.
Prophylactic, I told you, has to be stopped
So
12 hours
okay.
prior.
Treatment dose means it means VD dose.
Yes. And therapeutic, 24 hours prior to the surgery.
Okay. Okay.
Okay. Patients
Okay.
who are at very high risk of thromboembolism require admission 3 days prior to the surgery for bridging. With
Okay.
in those patients, we give them IV unfractionated heparin till 4 hours if they are at
Okay.
very high risk.
Okay.
Post-operatively, so this was about the pre-operative, when you have to stop. Now, when will you restart? Okay,
Okay.
if there is high bleeding risk, so then in those cases you bridge you should start at least 48 hours after the procedure.
Okay.
And in case there is low risk of bleeding, then warfarin can be resumed. Here you will start 48 hours prior after,
Okay.
and primarily you mostly start LMWH. Here you can start directly warfarin if the patient is at low risk of bleeding. Okay.
Okay.
And bridging therapy with LMWH should be continued until you bridge, until the INR. You have to maintain a INR between 2 to 3. So until
Okay.
that range is maintained, you give both warfarin and heparin. And similarly, when you are bridging to LMWH, you have to maintain factor 10A levels between 0.8 to 1.2. Until you get that levels, you give both. Okay,
Bridging
understood?
therapy. 1 minute, ma'am. Previously,
Yeah.
bridging therapy with should be continued until. Okay. That means
Yeah.
bridging therapy from which to which?
Bridging in both cases. So, like before you are giving initially warfarin. 5 days
Okay.
prior to the surgery, you have to change into LMWH. Okay,
Okay. Okay. This
LMWH
is
will take some time to
post-operatively.
act.
Okay. So immediately after the procedure.
Pre-operate, both pre and post. You have to.
Okay.
Okay.
And this thing, warfarin is it has it is slow acting.
Warfarin, yes, to reach a therapeutic level, it will take some time.
Okay.
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 Then this is the same thing, irrespective of the risk of bleeding, you stop it 5 days prior. Okay.
Okay.
And before the surgery, you ideally check INR. If the INR is more than 1.5, then you give them vitamin K antagonist. Vitamin K you give. Warfarin is vitamin K antagonist, so you give them vitamin K. So vitamin K, which you give is phytomenadione. Okay,
Okay.
which is vitamin K only. Okay.
Okay.
Then when will you restart? If the patient is at low bleeding risk, then you can start warfarin itself. Okay,
Okay.
at 12 to 24 hours. And if you're giving LMWH, it can also be restarted 24 hours if it's therapeutic. Okay, high risk of
Actually,
bleeding, then you start LMWH after 48 hours only. Okay,
okay.
and
Uh,
simultaneously, in order to avoid it, you give mechanical thromboprophylaxis.
okay.
Okay.
High bleeding, low bleeding risk. Okay. When are we administering this? You said no something.
Vitamin K,
Vitamin K. When do we give?
you check INR prior to surgery. So
Okay. If it is more than 1.5.
if you, that
Oh.
means still warfarin action is there. So you give vitamin K.
Okay.
And
Okay. Okay.
warfarin is vitamin K
So
antagonist.
to combat warfarin action.
Yes, because you don't want bleeding,
So
right?
this is okay. Warfarin antagonist.
Yes, yes.
Okay. Okay.
Okay. So
Okay.
emergency gynecological surgery. Suppose a patient comes in the emergency. for any reason and she requires surgery and she's on warfarin, then what will you do?
If surgery can wait 6 to 8 hours.
So then if the surgery can wait for 6 to 8 hours, ideally you should wait and
Okay.
give them this vitamin K so that it
Okay.
can action can be reversed. Suppose a
Okay.
surgery cannot be
Okay.
delayed.
So this antagonist is useful only during surgery. Otherwise, we can just stop with that warfarin. It will
Exactly.
anyhow that dose will be reduced.
Yes.
Okay.
Yes.
Okay.
Giving time to stop. No, if the
Okay.
patient
Okay.
comes in emergency,
Yeah. Okay.
ideally you should try and if you can wait for 6 to 8 hours, it is good. You give vitamin
Okay.
K, wait and do the surgery. Okay.
Okay.
You cannot wait. Suppose it is an emergency ectopic, ruptured ectopic, you cannot wait.
Okay. Okay. Okay.
Then
So in
vitamin
case of emergency only. Okay.
is emergency. So in
Okay.
those cases, you have to give them this factor 4 prothrombin complex. So if vitamin this warfarin it blocks these four factor 2, 7, 9, 10, and thus causes anticoagulation. So
Okay.
you replace these factors only. So
Mm.
then it'll that anticoagulant function will be like coagulation function will be restored.
So for
Okay.
any patient who was on warfarin, we have to give these four factors.
If the
Because
surgery cannot be delayed.
if the surgery
Cannot be delayed. If surgery can be delayed for 6 to 8 hours, then you give vitamin.
okay, okay, that warfarin action will not be there anymore.
Yes.
Okay, okay. We are giving the antagonist as well as the all these four factors.
Yes.
Okay.
Okay. Then direct acting oral anticoagulants. These are epixaban, rivaroxaban, and edoxaban.
Okay.
Okay, and also dabigatran. So in this, it depends because these are excreted by kidney. So they
Okay.
affect the renal function. So you see whether the creatinine clearance is normal, it is more than equal to 30. Then you
Okay.
stop these 24 hours, okay, prior
Okay.
to the surgery. If it is less than 30, you stop them 48 hours prior.
Okay.
In case there is low bleeding risk. If there is high bleeding risk, creatinine clearance is normal, then you stop 48 hours prior. And
Actually, why are we stopping 24 hours prior, ma'am? If when it is more than 30.
because it is normal, no, it will be metabolized by kidney
Okay.
and excreted by kidney,
Okay.
right?
Mm. Okay.
And when will you restart post surgery? If there is low bleeding risk, you can restart. It doesn't depend on the this thing. It doesn't depend on renal function. Then, in
Okay.
any case, you can restart it after. In any case, you can restart it this 6 to 12 hours if there is low bleeding risk. If there is high bleeding risk, then you wait for 48 hours. Okay.
Okay.
Then about for
This is for
dabigatran.
commencing. This is for commencing even oral anticoagulant.
This is for only direct acting oral
Oh,
anticoagulants, these three.
okay.
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 For dabigatran, it is different. If there is low bleeding risk, then again here the renal clearance is if it is more there we had taken a cutoff of more than
Okay.
30. Here we
Okay.
have taken the cutoff of more than equal to 80. If it is more than equal to 80, then you stop 24 hours prior. 50 to 80, you stop 48 hours prior. 30 to
Okay.
50, you stop 72 hours prior.
30 to 50.
Okay. High if it is high
Okay.
bleeding risk
Yeah,
more
fine,
than
fine. When it
40.
is normal, okay, we are taking a longer duration. Okay.
So 1 to 3 days, 2, 3, 4 days.
Okay.
Like this you calculate. And recommencing is the same. If it is low bleeding risk, 6 to 12 hours post procedure, high bleeding risk, 48 hours.
Okay.
Okay. And suppose if the patient comes in emergency and the patient goes on direct oral anticoagulant, then what you will do, you will try if the surgery can be delayed, you will try to delay. If it is not possible, then
Mm.
you will give tranexamic acid, and also you will avoid NSAIDs because these are again anti platelets and can cause bleeding.
Okay.
And we have also have this antagonist for these. We have idarucizumab, which is which reverses the effects of dabigatran. You can give
Okay.
it as well. Okay.
Okay.
So this was about direct. acting oral anticoagulants. Then, if the patient is on antiplatelet, so there are two types of antiplatelet: aspirin and clopidogrel. Aspirin is safe. You can give it till the day of the surgery. It doesn't cause much effects. However, clopidogrel, it has to be stopped 7 days prior to the surgery or prior to the regional block. Okay.
Okay.
And we do not have any reversal agents for it. Okay.
Okay. Mm.
However, if patient presents in the emergency and has high risk, then what will you do? You will give them tranexamic acid and you will give them platelet, because it is antiplatelet. You give them two pool of donor platelets. Okay.
Aspirin we are stopping by 36 weeks itself, no ma'am, before labor.
Yeah, but like it can be continued till term.
Oh,
Usually
there
we
is no
stop it
harm. Okay.
because we are giving very low
Still
dosing.
on the safer side. Okay. Mm.
Yes.
And when there is early diastolic notch,
Yeah.
what is the dosage? Is 75 adequate or 150 to be
Now,
given?
recent guidelines say 150.
150. Okay.
Is there in the questions you have, because you, if you might be solving the question, it will be old questions. So the
Okay.
guidelines say 150. Now you give 150 only as a
150 and 150 to be continued throughout,
yes.
even if it is normal after second trimester.
Yes.
Okay. So once we start with 150, it has to be continued, same dosage only. Mm.
Yes.
Okay.
Okay, this you understood about clopidogrel. 7 days prior you have to stop. In case patient comes in the emergency, you give tranexamic acid and 2 pools of chloride.
Okay, because there is no antagonist. Mm.
Yes. Okay.
Okay, ma'am.
About it. Any doubts?
No, ma'am.